Hi, and welcome to another episode of MD Insights. I'm delighted to be here today with Dr. Michael Valente. Mike is a colorectal surgeon in the Department of Colorectal Surgery here at Cleveland Clinic, who's developed a really interesting type of practice, and it's some of the things that we're going to talk about. Mike, welcome, and thanks for being here today.
Thank you, Connor. Glad to be here.
So, well, let's start off about what brought you to even colorectal surgery, frankly. I mean, there's lots of areas people can focus on. What drew you to this?
Sure. Great question. Very common question from the patients, actually.
Yeah.
I think, we all do general surgery for at least 5 years, and we all find mentors or people that we look up to during that time. And the colorectal surgeons at my general surgery program were people that I wanted to be like, and they had a great practice. They were great personalities. They were fun to work with in the operating room, really skilled and just good teachers. And I wanted to emulate that. Plus, I like the type of operations that they did, of course.
Yeah, absolutely. There's plenty of variety. Everything from MIS to open to anorectal to what have you, and even endoscopy.
Absolutely.
We're lucky with all the different things we get to do.
Absolutely.
But you've kind of evolved, at least part of your practice now, towards a more complex abdominal surgery and particular cancer focus. Maybe tell us a little bit about that.
Sure. All of us at the clinic do all kinds of operations, but I was always drawn to the more of the open approaches and more of the complicated surgeries and kind of the recurrent cancer operations. And with that came the opportunity to do the HIPEC, or hyperthermic intraperitoneal chemotherapy operation, which is quite a big operation, which requires a lot of time and expertise and a lot of training. And I don't want to say I fell into it, but with my background of being more of a open operative surgeon and the type of cases, it was a nice fit for me.
Yeah, I think the way with the size of the team we have, we allow everyone focus on something that's interesting to them. And we certainly have plenty of those complicated cases that fit that niche that you're interested in. So tell us a little bit about HIPEC. So what's involved for those who mightn't realize?
Sure.
First, what's involved in the operation, and then maybe a little bit what kind of diagnosis or cases are suitable for this procedure.
Sure. In my practice, there's two main types of patients that would undergo the procedure, and they're very actually quite different type of patients. One is a condition called Pseudomyxoma. It's otherwise known as jelly belly. You may hear it called in the lexicon out there, and that's what we call Pseudomyxoma, which is usually from the appendix, sometimes from the ovary, and that is a gelatinous material that coats the entire abdominal cavity, which requires, the only treatment that works for it is complete removal of all those implants and the hot or heated chemotherapy to eradicate or get rid of those tumor cells, because standard chemotherapy doesn't work. On the other end of the spectrum are folks who colorectal cancer, what we would consider a type of stage 4 colorectal cancer, where they have implantation of tumor cells on the peritoneal cavity itself. Those patients, chemotherapy has been shown to work, but with limited success. And this procedure has shown promise in removing all the cancer implants and then providing intraperitoneal chemotherapy as well, in conjunction with regular systemic or IV chemotherapy. So it's a very specific group of patients that this is for, but we're seeing some good promising results.
So let's talk a little bit about the pseudomyxoma. So for patients, the peritoneum obviously is the inner lining of the abdominal cavity, and it lines the intestine and the inside of the wall of the abdomen. And it's a space where cells can move and shed and get stuck on different parts of the intestine. So it can be all over the abdomen, as you said. So the goal then is to take out all of the little bits that you see. And then, because this is a space that intravenous chemotherapy doesn't really effectively get to, you directly put in the chemotherapy at the end of the surgery. So the surgery involves taking out all the big affected bits, taking out all the microscopic stuff you can see, and then, so what do you do then? How do you give the chemotherapy?
Sure, great question. And as you said, we take out all the stuff we could see and feel, and then the microscopic things left behind is for the chemotherapy. So after we're done with the removal of the implantations or that part of the surgery, we then place catheters or tubing inside the belly cavity, and we instill chemotherapy through almost like a heart-lung pump machine that you have during that surgery, where that circulates the chemotherapy through the entire abdominal cavity at a proper temperature of about 42, 43 degrees Celsius, so pretty hot, 104 degrees Fahrenheit. And that washes out through the entire abdominal cavity for about an hour and a half. We're closely monitoring the patient and temperature and their blood pressure, et cetera. And then that formula gets washed out. We irrigate with water. And then we perform the remainder of the operation. We put things back together. Sometimes patients require a temporary ostomy. It's quite a long procedure, but quite effective.
Yeah, absolutely. And you strip it out from often everywhere from up under the diaphragm to down in the pelvis. And then for colorectal cancer, obviously, it can sometimes be a little more local, and often we can cure patients with a resection of one piece of intestine. But these are some of the more advanced tumors that shed, again, cells within the abdominal cavity. And so the surgical principles are similar?
They are similar. Take out whatever you possibly can. In our world, if we cannot achieve removing all of the tumor, then we generally do not give the chemotherapy. So yes.
So tell me about how patients, how do you evaluate patients to decide if they're the right candidates for this? Because obviously we don't want to offer a patient a big operation if they're not going to have a high likelihood of success. So how do you stage these or categorize these intraperitoneal tumors and determine who's most appropriate for treatment?
Yeah, that's a great question, a very common question from oncologists and patients alike. And it's very important. We do our very, very best to stage the patient preoperatively, meaning that we don't want to take them to the operating room and then find out that we can't do the operation halfway through, which is very rare. So things that we do, CAT scan, MRI, either one of those in conjunction with each other or separately, gives us about a 75% chance of knowing exactly what's going on inside the belly. So not perfect. Another newer development over the last 5 years or plus has been diagnostic laparoscopy, where we'll put a small camera in the belly and take a look around. And we do a staging scoring system. It's the peritoneal carcinomatosis index, or PCI, and it takes the body and it divides them up into 13 different regions in the belly. And the surgeon can then say how much disease is in each section, and we add it up. And then we use those numbers to tell us, is it possible to do? Is it safe to do? And we go off those numbers. So both CAT scan, MRI, sometimes diagnostic laparoscopy, and of course the overall patient fitness and health plays a major role as well.
So that's a great explanation, Mike. Thank you. I think that's very helpful for people. Part of the challenge, though, is with imaging. Often these peritoneal tumors, they're only a couple of cells thick, and CT scan and even MRI scan, which has better resolution, doesn't really show it. So to your point, you have to look, and laparoscopy works well for some patients, but sometimes you just have to open the abdomen to check, right? Because if somebody's had surgery before and everything is stuck together with adhesions from the prior surgery, you can't exactly put a laparoscope in. So how do you approach that discussion with the patients and counsel them through that?
Yeah, great question. And overall worldwide data shows about up to 10 to 15, sometimes 20% of patients we will take to the operating room and we cannot perform the operation. So that, of course, is disheartening for the patient and the surgeon. And I talk to the patients, and most of the patients, I think the vast majority understand what we're dealing with, and they understand that sometimes for me to not do the operation is the right thing when we get in there, and it's deemed too risky or too much disease burden where we will back out. I don't like to use that word back out, but we make a planned retreat, if you will, and get them back to their regular systemic or IV chemotherapy. And like I said, about my experience has been about 10% of patients overall who we cannot do the operation on once we get to the operating room.
So obviously you've got a lot of patients sent to you from a lot of different places, so you've got a lot of experience with this, but often it's challenging for patients to get an opinion around carcinomatosis because not many people have the experience that you have to approach it surgically. So are you able to interact with patients virtually? Do you find that virtual healthcare is really helping?
Yeah.
What are your thoughts about how we do this in the future, particularly with the transition to virtual health?
Yeah, I found that the virtual platform for these conditions have been fantastic. Patients do come from all over the country per se, and a 30-minute, 1 hour virtual informational contact with the patient is great for this type of disease process, because it works so nicely. We can review all the films, we talk about everything, and you don't really need to come to Cleveland just to talk about this, because a lot of the patients have had surgery elsewhere. I'm reviewing their old operative reports, looking at their films, talking to their oncologist before they even talk to them. So the virtual platform has actually been quite remarkably great for this for my practice.
Yeah, I think it's really important, and it allows us get information to patients easily, which is what it's all about. And then tell me about teams, because some of these procedures would be collaborative or multidisciplinary. You'd be working with GYN or urology or others. So
Yes.
How do you approach the multiple surgeons in a case teamwork side of things?
Well, it's great here at the Cleveland Clinic. Our gynecological oncology team, there's at least 3 or 4 of the staff members perform HIPEC as well for ovarian and gynecological reasons. So I work with those team members very closely, because almost every female patient who has this procedure will most likely have their ovaries removed, because that is a major site of implantation of tumor cells. And very often a hysterectomy may be performed as well. Very rarely, urologically speaking, the bladder does not often have to be removed or have surgery on it. So, but the gynecological oncology team, urology team, have done, and anesthesia, of course, they're a big part of the operation. Right. It's a great team here.
Yeah, we're lucky to have a good multidisciplinary crew. So then moving on to next stages, an important part of what we do is the surgical education and training. So how do you approach training residents or fellows in this type of surgery?
Yeah, great question. Well, I'm blessed to be the program director here for the last 4 years. We have the best trainees in the world. We really do. And it makes my job a lot easier when we get the best of the best from around the country and the world. We have 5 North Americans, and we have 4 international fellows here. So it's really great. This is a great program for them. This is a great procedure for them to help learn multiple different ways of doing an operation, because this operation is sometimes 5 or 6 different operations in one. It could take between 5 and 14 hours long, I think is my longest one so far. So the fellow, which is, they're already graduated from general surgery, and they're doing they're assisting me in this operation. They're learning the technique. And, this operation's great for training. Not, with that being said, I'm doing all the operation, of course, but they're assisting. And like I said, multiple different aspects of anatomy, technique, and it's a great experience for them.
Yeah, I think it's great. It's something they don't get exposed to many other places, and it's certainly a kind of formative operation in your experience, seeing how these complicated things are done and helping us as surgeons when we do them. So, and it's important in kind of passing it on to the next generation and ultimately expanding it carefully to patients in other centres.
Absolutely.
So Mike, listen, I really appreciate your time and expertise and thoughtfulness in your answers, obviously for looking after the patients with such complex conditions, but also spending time with me here on MD Insights. Really appreciate your discussion. Thank you.
My pleasure. Great honor. Thank you, sir.